Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. In this session, I will be discussing a very important topic in the cardiology, that is the jugular venous pulse or the jugular venous pressure. Okay, so you see the first important question, that is internal jugular vein pressure determines the pressure of which particular chamber? Right atrium, right ventricle, left atrium, left ventricle. So internal jugular vein, right, it finally opens into the superior vena cava, and superior vena cava it opens into the right atrium. So whatever the pressure is there within the right atrium, it is reflected into the jugular vein. So the internal jugular vein pressure determines the pressure of the right atrium. Okay, and the next important question that you need to know parallelly is which particular pressure represents the left atrial pressure. Okay, so left atrial pressure, it is determined by pulmonary capillary wedge pressure, right? So whatever is the pressure within the pulmonary capillaries, that will be equivalent to your left atrial pressure, and whatever is the pressure within the internal jugular veins, that will be the pressure of your right atrium. Okay, now following that, first let me discuss a little bit of anatomy of the jugular vein. So why is that the internal jugular venous pressure equivalent to that of right atrial pressure? Let me discuss that. So if you see the basic anatomy of the jugular vein, there are two sets of the jugular vein. Right, there are two sets of the jugular vein. And what are those two sets of jugular vein? That is external jugular vein and the internal jugular vein. Right, external jugular vein and internal jugular vein, right? And this particular external or the internal jugular vein, it is present on both right and as well as the left side. So you take the left side external jugular vein and right side external jugular vein, that is left external jugular vein and right external jugular vein. Both of them together, they drain into the subclavian vein. Right, both of them, they drain into the subclavian vein. Okay, now the internal jugular vein, it joins with the subclavian vein. Right, IJV, internal jugular vein, it joins with the subclavian vein more medially to form the brachiocephalic vein. So the internal jugular vein, it joins the subclavian vein more medially to form brachiocephalic vein. All right, now then you take these brachiocephalic veins. These particular brachiocephalic veins, they finally both, so you have the brachiocephalic vein on the right and as well as the left. So this particular right and as well as the left brachiocephalic vein, both of them, they join to form the superior vena cava. Right, both of them, they join to form the superior vena cava, and this particular superior vena cava delivers the deoxygenated blood to the right atrium of the heart. Right, that will deliver the deoxygenated blood to the right atrium of the heart. So this is about the basic anatomy of the jugular vein. Okay, so your superior vena cava, so this will be your right atrium, this will be your left atrium. So right atrium, which is draining the venous blood from the superior vena cava, let me tell you, it is in the direct connection, right? It is in direct connection with the internal jugular vein. So that is the reason why your right atrial pressure directly reflects to the jugular vein, and you don't have any valves between the right atrium and as well as the jugular vein. So whatever is the pressure within the right atrium, that is reflected into the jugular vein. And that is the reason why right atrial pressure is equivalent to that of the internal jugular vein or jugular venous pressure. Now, how much is the normal jugular venous pressure? Normal jugular venous pressure, it is 6 to 8 centimeters above the right atrium. Right, it is almost 6 to 8 centimeters above the right atrium. Now, this jugular venous pressure, it is wavy in nature. Right, when you do the inspection of the jugular venous pulse, right, if you do the inspection of the jugular venous pulse, you will notice or you will observe the presence of the waves within the jugular venous pulse. And these particular waves, I will discuss that in detail. See, what is the very important difference between the jugular venous pulsations and as well as the carotid pulsations? Let me discuss the differences between these two. So, if you observe the jugular venous pulse, it is wavy in nature or it has the wavy form, right, and it can be visible, whereas the carotid pulsations, it is pulsatile in nature. So, if you take the carotid pulsations, these are the pulsatile in nature, and the next important point is that these are being felt. Okay, these are being felt. They cannot be seen. That means they are palpable. Right, that means they are palpable. And the next important point is the jugular venous pulsations, they are seen lateral to sternocleidomastoid. Right, lateral to sternocleidomastoid. Whereas the carotid pulsations, they are seen medial, right, medial to sternocleidomastoid. Right, they are being felt medial to sternocleidomastoid. Next, then followed by that, if you see the jugular venous pulsations, you have the presence of the hepatojugular reflex. That means when you apply the pressure over the right hypochondrium, the jugular venous pulsations increases. So, the hepatojugular reflex, right, the hepatojugular reflex, it is present in case of the JVP. Whereas, if you take in case of the carotid pulsations, the hepatojugular reflex, it is absent. Right, the hepatojugular reflex is absent in case of carotid pulsations. So, these are some of the differences between the JVP and as well as the carotid pulsations. Now, let me discuss in detail about the JVP. Right, I said you they have the wavy form and they are visible in nature. Now, let me discuss what are those waves and what is their importance. So, the first question is, all of the following phases of the jugular venous pulse and their causes are correctly matched except. First option, C wave, it represents the onset of atrial systole. Second option, AX descent represents the atrial relaxation. VY, it represents the emptying of blood from right atrium into the right ventricle. YA ascent, filling of the right atrium from the vena cava. So, now these are the options. First, what we will do, like we will discuss the waves, right? We will discuss the waves and then we will come back to this question once again. But before going on to the discussion of the waves and corresponding events in the cardiac cycle, first you need to know what are the phases of cardiac cycle, right? So, first you need to know what are the phases of the cardiac cycle. See, cardiac cycle, the total duration is, right, the total duration of the cardiac cycle is around 0.8 seconds. Now, out of these 0.8 seconds, you have the events, that is systole, and then you have the events, that is the diastole. Right, so you have the systolic events and then you have the diastolic events. So if you take the systolic events, systole it is around 0.3 seconds, diastole it is around 0.5 seconds. Right, systole is around 0.3 and diastole is around 0.5 seconds. Now you take the events in the systole. Right, so there are totally 3 events in the systole, and these particular 3 events, they include number 1, isovolumetric contraction. Right, isovolumetric contraction. So this will be the first event in the systole, and you take the second event in the systole, that will be a rapid ejection. Right, and the third event in the systole will be reduced ejection. Right, that will be the reduced ejection. So these are the 3 events in the systole: isovolumetric contraction phase, rapid ejection, and as well as the reduced ejection. Now coming to the diastole. So in the diastole there are 4 events, but some textbook says there are totally 5 events, which is around totally 0.5 seconds. Now what are those events in the diastole? So if you take in the events in diastole, that includes number 1, isovolumetric relaxation phase. Right, that includes the isovolumetric relaxation phase. Then the second event is the first rapid filling. Right, the second event is the first rapid filling, and next is the reduced filling. Right, and this particular reduced filling, it is nothing but diastasis. Right, it is nothing but diastasis. And after this reduced filling, we also have the second rapid filling. Right, second rapid filling, and this second rapid filling of your ventricular event, it corresponds to the atrial contraction, or it corresponds to the atrial systole. It corresponds to your atrial systole. So second rapid filling means what? It is the late diastolic events. So these are the 4 phases, but some textbook gives even one more event, that is before isovolumetric relaxation, the onset of relaxation, that is the protodiastole. Okay, so these are the events in the diastole, right? Now, once you understand these particular phases in the cardiac cycle, then we will be able to correlate the phases of the cardiac cycle with the JVP. Okay, now, so I said you the JVP, that is jugular venous pulse, it is waveform, or it has the waveform, and it reflects, right, jugular venous pulse, it reflects the pressure changes in the right atrium. Right, it reflects the pressure changes within the right atrium. And there are totally 5 waves. Right, there are totally 5 waves, out of which you take A, C and V. They are considered as the positive waves. You see this A, C and as well as V. These are considered to be the positive waves. That means these, during this particular A, C and V, the pressure in the right atrium increases. right? The pressure in the right atrium increases. Whereas you take this X and as well as the Y. So X and as well as Y, both of these, they represent the right atrial pressure, right? Right atrial pressure is reduced. So that is what is your X and as well as Y wave. So these are the 5 waves, that is A, C, X, V, Y. Out of which A, C and as well as V, the right atrial pressure is more, and X and Y, the right atrial pressure is reduced. They are considered as negative waves. Which one? The X and Y. Now, let me tell you what these waves corresponds to. To which particular event of the right atrium these particular waves corresponds to, let me discuss that. So, you take the A wave. So, A wave, it corresponds to the atrial contraction. So, it is a positive wave. Right, it is a positive wave and it corresponds to, or it is produced by right atrial contraction. Whereas if you take the X descent, see, X descent, it is what? It is a negative wave. And what does that represent? It represents the atrial relaxation. So what do you mean by the word negative wave? It is the condition, or it is a waveform due to decrease in pressure, right? Decrease in the pressure in the right atrium. Okay. And this particular X descent, it occurs due to atrial relaxation. Right, it occurs due to the atrial relaxation. So whenever the atria is being relaxed, the pressure within the atria reduces, right? And that is why you will have the X wave, right? And you take the C wave. So you have to understand that whenever the atria is relaxing, what the ventricle will be doing parallelly? The ventricle will be contracting. Okay, so you observe or you see this image. So this will be your 4-chambered heart. So what is the event we are discussing? We are discussing about the C wave, and we have discussed that X wave is the condition or the wave due to atrial relaxation. So when atria is relaxing, what the ventricle will be doing? The ventricle will be contracting. When ventricle contracts, what will happen to the pressure within the ventricle? The pressure within the ventricle increases, and this increased pressure will exert on the ventricular surface of the tricuspid valve. So thereby what will happen to your tricuspid valve? The tricuspid valve, it closes and it bulges, right? Tricuspid valve, it closes and it bulges into the right atrium, right? The tricuspid valve, it closes and it will bulges into the right atrium. So thereby what will happen to your right atrial pressure? Right atrial pressure, it further increases. Right atrial pressure, it further increases, okay, and that will give rise to your C wave. Okay, so C wave is due to what? C wave, it is due to bulging of cusps into right atrium. That will cause increase in the pressure and that will result in the development of the C wave. Then you take the V wave. V wave is what? V wave, it is a positive wave. That means the V wave represent the pressure rise within the right atria, right? The V wave represent the pressure rise within the right atria, and this particular V wave, it is due to venous return. So during the V wave, venous return occurs to the right atria, right? Venous return occurs to the right atria. Okay, and what is that particular venous return? It is both superior vena cava and as well as the inferior vena cava. They will drain the venous blood, and thereby what will happen to the pressure within the right atria? Increases. So you have to understand the sequence. So initially you had a X wave, that is atria has been relaxed, and after the atria has been relaxed, the SVC and IVC will drain its blood, venous blood, and thereby the pressure within the right atria increases. and that will be reflected into the jugular vein, and thereby you will have a V wave. Okay, so V wave is due to venous return. Then you take the Y wave. See, during the V wave, what has happened, right? So the venous blood has entered into the right atria. So once the venous blood has entered into the right atria, what has happened to your right atrial pressure? Right atrial pressure is increased. Right atrial pressure is increased. So once the right atrial pressure is increased, you have to understand that these particular valves, right, that is your tricuspid valve will open. Once the tricuspid valve opens, the blood from the right atria, it enters into the right ventricle. So once the blood from right atrium gushes into the right ventricle, what will happen to the pressure within the right atria? The pressure within the right atria, it reduces, and that will result in Y wave. So Y wave, it is a negative wave. So it tells you that the pressure in the right atrium decreases. Okay, and why is this Y wave due to? Y wave is due to atrial emptying, right? Atrial emptying. Okay, so these are the waves in the JVP. So A wave is due to atrial contraction, X wave is due to atrial relaxation, C wave is due to bulging of the cusp into the right atria, V wave, it is due to venous return into the right atrium through both SVC and as well as IVC. And then if you take the Y descent, right, Y descent is due to the atrial emptying. Now let me just correlate the JVP waves with the cardiac cycle events. So right, so on one side you need to know what are the mechanical events, the other side you need to know what are the phases of that particular cardiac cycle, and what are the waveforms of the JVP. So you take the A wave. During A wave, what is the mechanical event? The mechanical event is atrial contraction, right? Atrial contraction. So when atria is contracting, right, when atria is contracting, the ventricle will be in the later part of the diastole. The ventricle will be receiving the second rapid filling. So the phase of the cardiac cycle is end diastole, right? The phase of the cardiac cycle is the end diastole. And you take the C wave. C wave, what is a mechanical event I have discussed? That is tricuspid valve bulging. Right, tricuspid valve bulging. So when do you think the tricuspid valve will bulge? What will be the phase of the cardiac cycle? That will be your isovolumetric contraction. And your isovolumetric contraction is nothing but the early systole. Right, so that will be the early systole. Okay, now coming to the X wave. See, ACXVY. Now if you take this particular X wave, what is the mechanical event? That will be atrial relaxation, right? Atrial relaxation. Now you need to know which particular phase of the cardiac cycle will be your X wave. So when atria is relaxing, what the ventricle will be doing? The ventricle will be contracting, and this particular ventricle will be in the mid-systolic phase. So after early systole, what is the next event in the cardiac cycle? That will be mid-systole, right? That will be your mid-systole. Okay, next, then you take the V wave. What is the event which we have discussed in the V wave? V wave, it corresponds to the venous return, right? Venous return into the right atrium. So venous return means the atria is still in the phase of the diastole. Then what the ventricle will be in? The ventricle will be in the late systole, right? The ventricle will be in a state of the late systole. That means it will be an ejection phase into the aorta, right? And please remember, the cardiac cycle events, they correspond only to the ventricle. right? All the events in the cardiac cycle, whatever has been said to you, they will be ventricular events, they will not be atrial events. Okay, next, coming to your Y wave. So what does the Y wave correspond? What will be the mechanical event? Y wave, it is the atrial emptying. Right, Y wave will be atrial emptying, that is early ventricular filling. Right, early ventricular filling. So this particular Y wave, it corresponds to the early diastole. So what will be the atrial event? That will be atrial emptying. Why the atria is emptying? Because the pressure within the atria is increased. So the tricuspid valve will open. Once the tricuspid valve opens, the blood from right atria will gush into the ventricle, and that will be nothing but your early diastole, right? Which is nothing but it is a first rapid filling phase, right? Which is nothing but first rapid filling of the right ventricle. Okay, so that will be your early diastole. See, this particular table is a very important multiple choice question, right? So it is like correlating the waveforms with the mechanical event of the atria and correlating the same with the phases of the cardiac cycle. Now, after having discussed about the waveforms, let me discuss like how to measure the jugular venous pulse or jugular venous pressure. So you need to know how the position of the patient should be. Most patients have to be examined in the 45 degrees position. So the position of the patient should be right 45 degrees position. Okay, see, but there can be little variation in those individuals with high venous pressure. A greater inclination is required, but in those individuals with low jugular venous pressure, a lesser inclination is desirable. But overall, the effective method of measurement of the JVP can be done in 45 degrees position. Okay, right? And yes, so this will be your 45 degrees position. But please remember, how can you correlate the waveforms is whenever you are seeing the JVP can be seen. Whenever you are seeing the JVP, simultaneously you need to palpate the left carotid artery. Right, simultaneously you need to palpate the left carotid artery. Okay, when you palpate the left carotid artery, you can make out the waveforms easily. Or if you are not doing the left carotid artery palpation, you need to auscultate over the chest and simultaneously you need to see the JVP. Thereby you will be able to make out the events of the cardiac cycle and as well as the waveforms. Okay, now the question is how to measure the JVP. See, bedside, how you can measure the JVP is by using two scales. Right, by using two scales. Now out of which you have to keep the first scale at the upper level of the JVP. Right, so this will be the first scale. Right, this will be the first scale. So first scale you have to keep at the upper level of the JVP, and this will be the second scale. Right, this will be the second scale. So second scale, right, you have to keep exactly perpendicular to the first scale. Right, exactly perpendicular to first scale. Okay, so this is what should be the position of the two scales. First scale at the upper level, that should be parallel to the chest. Second scale should be perpendicular to that of the first scale, and exactly that has to be placed over the manubrium sterni, right, which is nothing but the angle of Louis. Why? Because exactly beneath the manubrium sterni you have the presence of the right atrium, right, exactly 5 centimeters above you have the chest wall, right, exactly 5 centimeters above the right atrium you have the presence of the chest wall, that is your manubrium sterni. So this particular measurement, right, this is considered as, that particular measurement, this is considered as the jugular venous pulse. But to this particular measurement you need to add 5 centimeters, right, you need to add 5 centimeters. So how much is the normal JVP we have discussed? 6 to 8 centimeters above the right atrium. So measurement of the JVP bedside is a very important examiner's question even in your final exam viva. Okay, right. Now after having said this, let me go on to the discussion of the waves question, like what I have shown you in the beginning. All of the following phases of the jugular venous pulse and their causes are correctly matched, except C wave represents the onset of atrial systole, AX descent represents the atrial relaxation, VY that represents emptying of the blood from right atrium into the right ventricle, YA ascent filling of the right atrium from the vena cava. So the question asked is except, right, the question asked is except. So you take this particular C wave representing the onset of atrial systole is an incorrect statement. What does the C wave represent? The C wave, it represents the bulging of tricuspid valve. Right, it represents the bulging of the tricuspid valve into the right atrium. That is what the C wave represents. Okay, onset of atrial systole, it represents the A wave, right, whereas the remaining all options, AX descent, it represents the process of atrial relaxation. VY, it represents the emptying of the blood from right atrium to right ventricle. YA ascent, it represents the filling of the right atrium from the vena cava. Okay, so that is about your waves. Now let me discuss the abnormalities of this particular JVP, right. So if you see the question here, in the JVP, A waves are absent in atrial fibrillation, mitral stenosis, tricuspid atresia, sick sinus syndrome. So the answer in this question is the atrial fibrillation. Now why in atrial fibrillation there is absent A wave, let me discuss. So absent A wave is seen in the atrial fibrillation. Now the question is why. So if you take atrial fibrillation, here the atria, it contracts nearly around 200 to 300 times per minute. So when atria is contracting up to 200 to 300 times per minute, how will be the contraction? It will be just a feeble contraction. So when there is a feeble contraction, will there be any pressure rise in the atria? No. So there is no pressure rise because it's just a feeble contraction. Okay. So why? Because normally the atria has to contract at a rate of 70 to 90 per minute. When atria contracts at a rate of 70 to 90 per minute, it will be a complete contraction. right? It will be a complete contraction. Thereby, there will be pressure rise in the right atria and thereby you will have a wave. But here, the atria is contracting at a rate of 200 to 300 minutes, 200 to 300 times per minute. So, the rate of contraction is increased. So, the contraction will not be a complete contraction. It is just a feeble contractions. It is like a flickering of the contractions. Okay. So, that is the reason why the pressure rise will not be there in the atria and thereby there is no A wave, right? Thereby there is no A wave. So, there will be absent A wave, right? Next. Then followed by that, what are the other abnormalities? So, the other abnormalities of the A wave is like we have a giant A wave and then we have a cannon A wave. So, where is that you will have a giant A wave? And where is that you will have a cannon A wave? Let me discuss both of them. Giant A wave in JVP, it occurs in all except junctional rhythm, pulmonary hypertension, tricuspid regurgitation and then complete heart block. So, what do you mean by the word giant A wave? Giant A wave means the pressure within the right atrium is increased more than normal. Right? Pressure in the right atrium is increased more than normal. That is the point when you have the presence of the giant A wave. Now, for the giant A wave to occur, what will be the reasons or what will be the etiologies? See, when your right atrium is contracting, right, when the right atrium is contracting, the blood from the right atrium should enter into the right ventricle comfortably without any obstruction. But for suppose, if there is any obstruction at the level of the tricuspid valve, right, if there is any obstruction at the level of, right, if there is any obstruction at the level of the tricuspid valve, then right atrium, it has to contract very strongly. Right, then right atrium, it has to contract very strongly. So, when right atrium contracts very strongly, what will happen to the pressure in the right atrium? The pressure in the right atrium also increases abnormally high. Okay. So, obstruction at the tricuspid valve, that is tricuspid stenosis, right, that is tricuspid stenosis and then right atrial myxoma. Okay. So, if there is any right atrial myxoma, what happens here? See, this is your right atrial myxoma. So, if there is right atrial myxoma, that will overlap the tricuspid valve. Once it overlaps the tricuspid valve, the blood from the right atrium does not move to the right ventricle comfortably. Right atrium has to contract forcibly to send the blood from right atrium to right ventricle, and thereby you have the presence of the giant A wave. So, obstruction at the tricuspid valve will also be the one which will cause the giant A wave. Then, next, the other clinical scenario where you can have giant A wave is the condition with increased resistance to RV filling. What did I tell you? When right atrium contracts, right ventricle should be in a position to receive the blood. But if the pressure within the right ventricle is more due to any pathology, then right atrium, it has to contract very strongly to push the blood into the right ventricle. So, any resistance in the right ventricular outflow tract, right, any resistance in the right ventricular outflow tract, that will cause the increase in pressure in the right ventricle. Subsequently, it will increase the right atrial contraction and thereby the pressure rise within the right atria increases, resulting in the giant A wave. So, Conditions with increased resistance to RV filling. That includes number 1, pulmonary stenosis, right? Number 2, pulmonary hypertension. Right? Pulmonary hypertension. So these are the 2 conditions where right ventricular pressure increases. Right? These are the 2 conditions where the right ventricular pressure increases. So right atrium has to contract forcibly to push the blood into the right ventricle. Thereby, in the right atrium, the pressure rise will be more, and that will result in the giant A wave. That will result in giant A wave. Then, followed by that, the another important abnormality of the A wave is the Cannon A wave. Now, when do you get this particular Cannon A wave? So, Cannon A wave is what? Cannon A wave, it is like the pressure rise in right atrium is more than, right, it is more than pressure rise in the right atrium due to giant A wave. Right? So, in giant A wave also the pressure rise will be there, and in Cannon A wave also the pressure rise within the right atrium will be there. But the pressure rise within the right atrium in case of Cannon A wave is much more than compared to that of the pressure rise within the right atrium compared to that of your giant A wave. Okay. Now, what are those clinical conditions? Okay, first of all, let me discuss one important concept, that is, when right atrium contracts, right, when right atrium contracts, right ventricle should relax. When right atrium contracts, the right ventricle should relax. That is the point when, the right atrium can send the blood into right ventricle. Or it is like, when right atrium contracts, what should happen to the tricuspid valve? The tricuspid valve, it should open. Then the blood from right atrium will enter into right ventricle, and thereby you will have a normal A wave. But for suppose, right, if right atrium and right ventricle, both of them, if they contract simultaneously, right, both of them, if they contract simultaneously, which one? Right atrium and as well as right ventricle, both of them, they are contracting simultaneously. When both of them, they are contracting simultaneously, the tricuspid valve, it will be in a closed state. Right, the tricuspid valve, it will be in a closed state. You understand that? So you see here, where will you get that clinical scenario? You will get that particular clinical scenario in patients with the complete heart block. In patients with complete heart block, you see here, this is the AV node. When AV node is completely blocked, the individual will result in what is called a complete heart block. Whenever there is a complete heart block, right atria will contract on its own and right ventricle will contract on its own. Now, let us assume that when right atrium and right ventricle are contracting simultaneously in patients with complete heart block, what will happen? It will be a scenario where right atrium has to contract against a closed tricuspid valve. So, you just assume now, if right atrium has to contract against the closed tricuspid valve, the pressure rise within the right atrium is very, very high, and that will result in a wave called the Cannon A wave. And you will come across the same scenario during junctional rhythm. right? You will come across the same scenario during the junctional rhythm. See, even during junctional rhythm also, junctional rhythm means what? It is the impulse which is originating from the AV node, right? It is the impulse which is originating from the AV node. So here what will happen? During junctional rhythm, the impulse generates within the AV node and the impulse is given to the right atrium and as well as right ventricle simultaneously. That means both of them they contract simultaneously. So when both of them they contract simultaneously, the pressure rise within the right ventricle will close the tricuspid valve. So right atrium, it has to contract against the closed tricuspid valve. Thereby the pressure rise within the right atrium is so high, resulting in what is called the Cannon A wave. Okay, next, the other condition where you will have the presence of the Cannon A wave is atrioventricular dissociation, right? Atrioventricular dissociation with ventricular tachycardia, right? Atrioventricular dissociation with ventricular tachycardia. Okay, so these are the three conditions. Number one, complete heart block. Number two, during junctional rhythm. Number three, atrioventricular dissociation with ventricular tachycardia. So these are the conditions where you will have the presence of the Cannon A wave. So we will see a question now. Giant A waves in JVP occurs in all except, right? The question asked is except junctional rhythm, pulmonary hypertension, tricuspid regurgitation, and then the complete heart block. So the answer is not CO here. So the answer in this particular clinical condition is the tricuspid regurgitation. In tricuspid regurgitation, you don't have the presence of the giant A wave. Whereas in junctional rhythm, pulmonary hypertension, even in complete block, in early stages of the complete heart block, you can have the presence of the giant A wave, right? And you don't have that giant A wave in case of your tricuspid regurgitation, right? Now, you see one more question, right? The same. In JVP, A waves are absent in the atrial fibrillation. This was the first question what we have discussed. So, let me summarize about the abnormalities of the A wave. So, large A wave seen in patients with tricuspid stenosis, pulmonary hypertension and right atrial myxoma. Presence of Cannon A wave that is seen during the junctional rhythm and AV dissociation with ventricular tachycardia and complete heart block. Absent A wave seen in patients with the atrial fibrillation. So this is about the summary of abnormalities of the A wave. Now followed by that, let me discuss the abnormalities of the X wave and as well as the Y wave and V wave. So in JVP, Y descent is absent and X wave is prominent, right? So what are the conditions that you will have? Restrictive cardiomyopathy, cardiac tamponade, constrictive pericarditis, right ventricular failure. So you will have this particular scenario in patients with the cardiac tamponade, right? Why and all we will discuss now. So we will discuss the abnormal waves and then come back to the same question. Abnormalities of X and Y wave and then come back to this question. So you take the abnormalities of the X wave. So what did I tell you why you will have the presence of an abnormal X wave? Okay, first of all, what is this particular X wave? It represents the atrial relaxation. Right, it represents the atrial relaxation. Okay, so whenever there is an atrial relaxation, the pressure in the atria decreases, so it will be a negative wave. Okay, now let me discuss what all would be the abnormalities. So the abnormalities of X wave, right? Abnormalities of the X wave. Number one, reversal of X wave. Right, number one, reversal of the X wave. where do you have the X wave being reversed. And second important abnormality is the conditions where the X wave is accentuated. Right, the conditions where the X wave is accentuated. Now, let me discuss about the reversal of the X wave. Reversal of the X wave, that is, instead of being a negative systolic collapse, it becomes a positive systolic wave. So, you instead of a negative wave, you will have a positive wave. Now, where do you have that? You will come across this particular scenario in patients with the tricuspid regurgitation. And I'll explain you. Why you will have this, I'll explain you. So, consider this is your 4-chambered heart, tricuspid valve, and then the bicuspid valve. Now, what do you understand by the word tricuspid regurgitation? Tricuspid regurgitation is that whenever the right ventricle contracts, you are aware that right atrium will be in a phase of relaxation. What is tricuspid regurgitation? Tricuspid regurgitation is the scenario where when the right ventricle contracts, the blood from the right ventricle, it enters into the right atria. Right, the blood from the right ventricle, it enters into the right atria. That is called tricuspid regurgitation. Actually, some amount of blood, it enters into the pulmonary artery, but some amount of blood also enters into right atria. So, normally, whenever the atria is relaxing, the pressure within the atria, it should decrease. But what is happening? During the time of relaxation, in tricuspid regurgitation, during the time of relaxation, the right atrium is receiving tricuspid regurgitant blood. Thereby, what will happen to the pressure within the right atria? The pressure within the right atria increases. Okay, because actually during relaxation, the pressure in the right atria should reduce. But right atria in tricuspid regurgitation is receiving the regurgitant blood during right atrial relaxation. So that is the reason why the pressure within the right atria, instead of decreasing, it will increase. And thereby, it becomes a positive wave. Okay, that is what is called reversal of X wave. Then, what are the conditions where you have the X wave being accentuated? So, the pressure fall within the right atria is more than normal. That is what is the meaning of the X wave being accentuated. See, X wave is accentuated in constrictive pericarditis, right? Number 2, cardiac tamponade. Right? Number 3, restrictive cardiomyopathy. So, these are the conditions where the X wave is being accentuated. That means the pressure fall within the atria is more than normal in all these scenarios. I will explain in detail all these scenarios in the respective conditions. Okay. Now, so this will be the abnormalities of the X wave. So, let me discuss about the abnormalities of the V wave. So, what does the V wave represent? The V wave, it represents venous filling. Right, the V wave, it represents the venous filling. Now, if you see the abnormalities of the V wave, we have one particular scenario where the amplitude of the V wave will be increased. And where do you have that? You will have that in patients with tricuspid regurgitation. So in tricuspid regurgitation, the V wave is increased. Now why the V wave is increased in tricuspid regurgitation, let me explain you. So consider this is your 4-chambered heart. This will be your tricuspid valve. This is your mitral valve. So in tricuspid regurgitation, what will happen during the ventricular systole? Right, during the RV systole, the blood from the right ventricle, it enters into the right atrium. Right, the blood from the right ventricle, it enters into the right atrium. That is during right ventricular systole. That is what will happen in patients with the tricuspid regurgitation. So right atrium, it is receiving the SVC blood, because when the right ventricle is in stage of systole, right atrium is in a phase of diastole now. It is in a phase of receiving phase. It will receive SVC blood, inferior vena cava blood, and in tricuspid regurgitation, you also have the tricuspid regurgitant blood. So thereby, what will happen to your V wave now? The V wave amplitude increases. Why? Because V wave is usually, in a normal individual, it is only SVC and IVC blood. But here you have an additional tricuspid regurgitant blood. So that is the reason why the V wave amplitude or the V wave is increased. Okay. Now, after having discussed about the abnormalities of the V wave, now let me discuss the abnormalities of the Y descent. So what is this Y descent tells you? Y descent, it tells you that there is atrial emptying. Right, that there is atrial emptying. Okay. So atrial emptying, it corresponds to the early phase of diastole. Now what are the abnormalities of the Y wave? So if you take the abnormalities of the Y wave, number one, there is early deep Y descent. Right, there is early deep Y descent. The second important abnormality is the presence of deep Y descent. Right, the presence of deep Y descent. Third important abnormality is slow Y descent. Right, and fourth important abnormality is the absent Y wave. Right, the fourth important abnormality is the absent Y wave. So you take the condition where you have the presence of the early deep Y descent. The early deep Y descent, you will have that in patients with the tricuspid regurgitation. Now why do you have that early deep Y descent in tricuspid regurgitation? So if you see this 4-chambered heart, and this will be right atrium and right ventricle, and then left atrium and left ventricle. So in case of tricuspid regurgitation, what did I tell you just now? When the right ventricle is contracting, some blood enters into pulmonary artery and some blood enters into the right atrium. That is what will happen in patients with the tricuspid regurgitation. So in right atrium, what will happen to the pressure rise? The pressure rise will be more than normal, right? Because right atrium has received the SVC blood now. Right atrium has received the IVC blood. Right atrium has also received the regurgitant blood. So right atrium pressure has increased earlier than the normal time. Normally when SVC and IVC blood enters into right atrium, there is a pressure rise. But here the regurgitant blood also has entered. So the pressure rise within the right atrium is earlier than the normal time. So when the pressure rise within the right atrium is earlier than the normal time, what will happen? The tricuspid valve, it opens early. Right? Tricuspid valve, it opens early. When tricuspid valve, it opens early, there is the early emptying of the blood from right atrium to the right ventricle. and thereby you will have an early deep Y descent. Right, thereby you will have an early deep Y descent. That is what you will have in patients with the tricuspid regurgitation. Then, what is the condition where you have the deep Y descent? The deep Y descent, it occurs in patients with constrictive pericarditis. Right, it occurs in patients with the constrictive pericarditis. That is where you have the presence of the deep Y descent. So, in constrictive pericarditis, you have deep X descent, right? That is, X wave is accentuated, and in constrictive pericarditis, there is also deep Y descent. Then, the condition where you have the slow Y descent. So, if you take the slow Y descent, it occurs in patients with tricuspid stenosis and right atrial myxoma. Why? I will explain you. You see here. So, this is your four-chambered heart, and this is your tricuspid valve and mitral valve. So, if there is, if there is the tricuspid stenosis, what will happen? It will take more time for the blood to move from right atrium to right ventricle. The same thing is even if there is right atrial myxoma. When there is right atrial myxoma also, the right atrial myxoma will obstruct the tricuspid valve, and thereby it will take more time for the blood to move from right atrium to the right ventricle. So thereby that will result in the slow Y descent. Next, the condition where you have the absent Y wave. The condition where you have the absent Y wave. The absent Y wave, you will have that in patients with the cardiac tamponade. Right, you have that in patients with the cardiac tamponade. Now, why in case of cardiac tamponade there is absent Y wave is, let me explain you. So, if you see, this is your four-chambered heart, right? And in cardiac tamponade, what happens? In cardiac tamponade, there is abrupt increase in the pericardial pressure because of the accumulation of the fluid. Now, when there is abrupt increase in pericardial pressure due to accumulation of the fluid, what will happen to the pericardial pressure? The pericardial pressure is increased, right? The pericardial pressure is increased. So, once the pericardial pressure is increased, ventricles, they are unable to relax. Right, ventricles, they are unable to relax. There is no relaxation of the ventricles. The ventricles, they are unable to relax. So when ventricles, when they are unable to relax, do you think that the atria can send the blood into the ventricle? Right, do you think that the atria, can they send the blood into the ventricle? No. The atrial emptying does not occur. When atrial emptying does not occur, you will not have the Y wave. So absent Y wave is seen in patients with the cardiac tamponade, right? So this is about abnormalities of your A wave, X wave, V wave and Y wave. So if you see this question, in JVP, Y descent is absent and X wave is prominent. Where is that you will have? You will have that in patients with the cardiac tamponade. Whereas in constrictive pericarditis, what is that you will have? You have accentuated X wave, right? You have accentuated X wave and then deep Y descent, right? Deep Y descent. Okay, that is what you will have in patients with the constrictive pericarditis. Okay, so in constrictive pericarditis, you have accentuated X wave and then the deep Y descent, right? Next, followed by that. Now, yes, this question already we have discussed. All of the following phases of the jugular venous pulse and their causes are correctly matched except what? The C wave. Okay, so C wave, it does not represent the onset of atrial systole, it represents the bulging of the tricuspid valve into the right atrium. Next, the important concept in jugular venous pulse that you need to know is about the hepatojugular reflex or the abdominojugular reflex. See, how is this done? This is done by applying the firm pressure with palm of the hand over the right hypochondrium. So, you need to apply the pressure right with the help of the palm of the hand over right hypochondrium, right? So when you apply the pressure with the palm of the hand over the right hypochondrium, for how much time you have to apply the pressure? You have to apply the pressure for nearly around 10 to 15 seconds, right? You need to apply the pressure over the right hypochondrium for 10 to 15 seconds, and then you need to observe the JVP. Right, then you need to observe the JVP, right? Jugular vein is then observed. So what is that you will observe in a normal individual? What will happen in right ventricular failure? Let me discuss. So when you apply the pressure over the right hypochondrium, what is that you will observe is, you will observe that the jugular venous pressure rises. Right, the jugular venous pressure, it rises. But this jugular venous pressure, whichever is rising, it rises only transiently. Right, it rises only transiently. And this rise, whichever is there, it is only transient, and there will be rapid return to the baseline. Right, there will be rapid return to the baseline. That is what will happen in a normal subject. So whenever you apply the, or whenever you do a hepatojugular reflex, the jugular venous pressure, it rises only transiently with rapid return to baseline. That is what is called a negative hepatojugular reflex. Then, what do you understand by a positive hepatojugular reflex? Positive hepatojugular reflex, you will have that in patients with the right ventricular failure. And what is the definition of this? A positive hepatojugular reflex, it is defined by increasing JVP, right? It is defined by increasing JVP greater than 3 centimeters, which is sustained, right? Which is sustained for more than 15 seconds. In a normal individual, what will happen? Whenever you remove the pressure, right? When you apply the pressure, the JVP increases. But whenever you remove the pressure, immediately the JVP will return back to baseline. But in patients with the right ventricular failure, even upon removal of the pressure from the right hypochondrium, the pressure is still raised, or the pressure rise is still sustained for more than 15 seconds. That is what is your positive hepatojugular reflex. Okay. Now, you see the question. Which of the following is not true about the hepatojugular reflex? Seen in pulmonary stenosis associated with decreased afterload, seen in tricuspid regurgitation, may indicate the right heart failure. Okay. So, hepatojugular reflex, it is seen in patients with pulmonary stenosis, because in patients with pulmonary stenosis, there will be increased afterload on the right ventricle, and that will lead to right heart failure. Right, that will lead to right heart failure. And the next important point is, these patients with a positive hepatojugular reflex, there will be increased afterload on the right ventricle. right? There will be increased afterload on the right ventricle. So associated with decreased afterload is an incorrect statement. It is only when there is increased afterload on the right ventricle, there will be right heart failure. Right? There will be right heart failure. So once there is right heart failure, there will be a positive hepatojugular reflex. Right? There will be a positive hepatojugular reflex. Okay? And even in this tricuspid regurgitation, right? Even tricuspid regurgitation will progress to a state of the development of right heart failure. And it may indicate the right heart failure is also a correct statement. Okay? So which of the following is not true about the hepatojugular reflex? Associated with decreased afterload is an incorrect statement. It is associated with increased afterload. Now, let me tell you what are all the conditions associated with the abdominojugular reflex. Right? Number 1, right ventricular failure. And what is the most common cause for right ventricular failure or right heart failure? It is left ventricular failure. So even in left ventricular failure also you will have positive hepatojugular reflex. But when is that? When left ventricular failure leads to right heart failure, then you will have a positive hepatojugular reflex. And the next condition is in patients with constrictive pericarditis, you will have the presence of positive hepatojugular reflex. Then in patients with right ventricular infarction, then lastly restrictive cardiomyopathy. Right? Lastly restrictive cardiomyopathy. So these are all the conditions associated with the abdominojugular reflex or a positive hepatojugular reflex. Okay. Now, after having discussed about the hepatojugular reflex or abdominojugular reflex, let me discuss the clinical conditions where you have elevated JVP, the clinical conditions where you have decreased JVP. So, if you see the conditions where you have unilateral non-pulsatile increase in JVP, you will have that whenever there is innominate vein thrombosis. So innominate vein is what? It is your brachiocephalic vein thrombosis, or whenever there is superior vena cava obstruction or whenever there is SVC thrombosis, there will be non-pulsatile increase in the JVP. Right? Or non-pulsatile increase in the jugular venous volume. Okay? Or non-pulsatile increase in jugular venous pulse. Right? Now, what are the conditions where you have bilateral non-pulsatile increase? Bilateral non-pulsatile increase, you will have that in SVC obstruction. Whereas unilateral, it is innominate vein thrombosis, that is brachiocephalic vein thrombosis. And the other condition where you have bilateral non-pulsatile increase in JVP is massive, right? Massive right-sided pleural effusion. Right? So these are the conditions where you have bilateral non-pulsatile increase in the JVP. And now let me discuss the causes of pulsatile increase in the JVP. Whatever we have discussed until now, non-pulsatile increase in the JVP. That is unilateral non-pulsatile increase, bilateral non-pulsatile increase. So whereas bilateral pulsatile increase in JVP, if you take the cardiac causes, that includes the cardiac failure. Right, that includes the cardiac failure. Then tricuspid stenosis, tricuspid regurgitation, constrictive pericarditis, and next cardiac tamponade. Okay, so these are the cardiac causes for bilateral pulsatile increase in the JVP. And if you take the pulmonary causes, so if you take the pulmonary causes of elevated JVP, that includes COPD, that is chronic obstructive pulmonary disease, and then the cor pulmonale. And if you take the abdominal causes for pulsatile increase in the JVP, that includes the ascites and pregnancy. Right? Whereas the iatrogenic causes for increase in the JVP, that includes excessive IV fluid supplementation. Right? Excessive IV fluid supplementation. So these are all the causes for elevated JVP. Then you need to know what are the causes for fall in the JVP. Fall in the JVP, you will have that wherever there is fall in the blood pressure of the individual. That is in patients with shock. Right? That is in patients with the hypovolemia. Right? And you will have that in patients with the Addison's disease. Right? So these are the conditions where you have fall in the JVP, hypovolemia, shock, and as well as the Addison's disease. Now, after having discussed about the various clinical scenarios where you have elevated JVP and fall in the JVP, let me discuss one important clinical scenario. A 60-year-old man presents with progressive symmetrical lower extremity edema. Which of the following finding would be inconsistent with the diagnosis of right-sided heart failure? Presence of the Kussmaul sign, prolonged prothrombin time, diarrhea, elevated bilirubin level, pulsus paradoxus. So you take in patients with the right-sided heart failure, what all you will observe? You will have systemic venous congestion. Right? You will have systemic venous congestion. Right? That means you will have the congestion of the upper half and congestion of the lower half, because SVC and IVC, both of them, they are draining into the right atrium. So because of the impaired venous return from the inferior vena cava, there will be hepatic congestion. Right? Because inferior vena cava has to drain the blood into right atrium, and here the right heart is failed. So when right heart is failed, right ventricle, right, remember, right ventricle cannot send the blood into pulmonary artery. Right ventricle cannot send the blood into pulmonary artery, the pressure in the right ventricle increases. So right atrium cannot empty the blood into right ventricle. So right atrial pressure increases. So when right atrial pressure increases, SVC and as well as IVC, both of them, they cannot drain the blood into right atrium. So thereby the inferior vena cava pressure increases. So liver cannot drain the blood into the inferior vena cava because inferior vena cava pressure is increased. So there will be hepatic congestion. So whenever there is hepatic congestion, you know, like what will happen to the coagulation factors? The coagulation factors are not synthesized. There will be prolonged prothrombin time and your bilirubin is not metabolized. So there will be elevated bilirubin. And because of the IVC congestion, you take the mesenteric veins, superior mesenteric vein or inferior mesenteric vein, ultimately they have to drain into the portal vein. From the portal vein, the blood enters into the liver. From the liver, through the hepatic veins, it has to enter into the inferior vena cava. Right? So, from the GAT, the blood through mesenteric veins, right, that is through both superior and inferior mesenteric vein, ultimately they have to drain the blood into portal vein. From the portal vein, the venous blood enters into the liver. From the liver, the blood has to enter into the hepatic veins. From the hepatic veins, the blood has to enter into the inferior vena cava. But what has happened here? There is hepatic congestion. Your portal vein cannot drain the blood into the liver. Right? Portal vein cannot drain its venous blood into the liver. So thereby the pressure in the portal vein increases. When the pressure in the portal vein increases, obviously the pressure in the mesenteric vein also increases. So there will be edema of the gut wall, because GI wall cannot drain its venous blood into the mesenteric vein. So there will be edema of the gut wall. So because of the edema of the gut wall, the absorption of the nutrients does not occur, and that will make the individual to land up in diarrhea. And these individuals with right heart failure will also have the presence of Kussmaul sign. What is Kussmaul sign? I'll discuss. But please remember, in patients with right heart failure, you don't have pulsus paradoxus. Pulsus paradoxus, it is a feature of it is the feature of the cardiac tamponade. It is a feature of the cardiac tamponade. Okay, next. Now, let me discuss in detail about the Kussmaul sign. See, you take in a normal individual. In a normal individual or in a normal person, the jugular venous volume, it decreases during inspiration. Jugular venous volume decreases during inspiration. Why? Because during inspiration, the venous return will enter into right atrium. Your superior vena cava and inferior vena cava, both of them, it will drain into the right atrium. So thereby what will happen to jugular venous volume? The jugular venous volume decreases during inspiration. But what is Kussmaul sign then? Kussmaul sign is increase in jugular venous volume during inspiration. Increase in jugular venous volume during inspiration. That is what is called the Kussmaul sign. That is what is called Kussmaul sign. Now, what are all the conditions where you will have the Kussmaul sign? You will have that in patients with right heart failure. Any condition whichever will cause right heart failure, like you take tricuspid regurgitation, pulmonary stenosis, pulmonary hypertension, any condition which will cause right heart failure, you will have the presence of Kussmaul sign. Then you will have Kussmaul sign in patients with tricuspid stenosis. You will have Kussmaul sign in patients with constrictive pericarditis. You will have Kussmaul sign in patients with restrictive cardiomyopathy. In all these conditions, you have the presence of the Kussmaul sign. But please remember, the Kussmaul sign is absent in the cardiac tamponade, it is absent in cardiac tamponade and as well as the SVC obstruction. So in cardiac tamponade and SVC obstruction, you don't have the Kussmaul sign. So this is about your Kussmaul sign within the JVP. So this completes the entire discussion of your jugular venous pulse or jugular venous pressure. So the normal jugular venous pressure is 6 to 8 centimeters above the right atrium, and you need to know the waves and as well as abnormalities of the waves, and you need to know the conditions where there is increase in JVP and decrease in JVP. So with this, I'll wind up this important topic, that is jugular venous pulsations. Thank you very much.